Hello and welcome to our second Lunch and Learn. I wanted to thank everybody for calling in, Zooming in, and I want to thank all the representatives from the AAA to be able to provide this for us. This is really great. So we are recording. So I would ask everybody who is not speaking if they could please mute. And we are interested in your feedback. If you like this session, if you want to see more Lunch and Learns, please let me know so that we can go ahead and schedule these. And if you have any questions, you can go ahead and put them in the chat box because Samantha will be monitoring that and letting our speakers know. And with that, I'm going to turn it over to you, Samantha.
Thank you, Heather. Hello and welcome, everybody. My name is Samantha Hilker. I'm the Director of Strategic Initiatives with the American Ambulance Association. We're excited to be here with you today, and I want to say thank you to Heather and the Ambulance Association of Pennsylvania for hosting us. A few housekeeping items before I introduce our cost collection faculty presenting today. As Heather mentioned, please make sure your mic is muted to help minimize any background noise. We do have time dedicated for questions and answers, but please feel free to ask your questions in the chat box or raise your virtual hand at any time. We will do our best to answer all incoming questions in the time provided. However, if a question does not get answered, please email hello@ambulance.org and one of us will respond as soon as we can. I will be dropping some items, including the slide deck presented today, in the chat for downloading. And I will also share all these materials with Heather via email for anyone who might be interested in having them. And as Heather mentioned, this webinar will be recorded. With that, it is my pleasure to introduce our cost collection faculty today: Scott Moore, Brian Werfel, and Michelle Anderson. Scott, do you want to get us started?
Well, thank you, Samantha. Thank you, everyone, for joining today. Really, really appreciate it. We're going to talk about the exciting topic of CMS's ground ambulance cost collection, data collection. And so as they said, certainly at any time, just feel free. Although I can't see all of the folks on the screen, certainly feel free to raise a hand and hopefully Sam or one of the others will see it. If not, I'll keep an eye on the chat as we go along. As Sam said, my name is Scott Moore. I am one of multiple ambulance cost data collection faculty that have been traveling the country and developing the content for this this upcoming process for now. I think we're in year 4 or 5 now. For many of you who were selected in year 1 or 2, you were the, I say, victim of a delay due to COVID, although I think honestly, that has been not that COVID's been a good thing, but the delay has provided us with more time to prepare for submitting the data. As we always do, and I always jokingly say, trust a lawyer who tells you not to rely on what they're about to tell you. Just don't rely on it as legal, financial, or accounting advice. This is intended to be for informational purposes only, educational purposes, to make sure that you and your organization are ready to report their data. Because as you know, every EMS agency in this country, all 13,983 of them that bill Medicare over the course of a year, will have to report their data either this year or next year. We'll talk about that in a minute. So why is cost collection so important to not only your organization, but really EMS as a whole? And there are multiple reasons for that. One, this will be the basis upon which all payment or reimbursement for ambulance services in this country, this will be the reform of that process. So for years and years and years, the AAA has been arguing for those add-on 2, 3, and 22.6% add-on payments that CMS has had. But it has been our premise all along, and many other groups as well, that the CMS ambulance fee schedule does not reimburse ambulance services for appropriately or to cover their costs for the services provided. As a result of that, the Congress said and CMS said, all right, well, you need to prove it. Put money where your mouth is. We need data to suggest or support any change. We believe that this ground ambulance cost data collection will be the basis upon which they reform the payment system. Given that it's been 21 years since the last time, 22 years since the last time they did that, I'm presuming that for many of us, it'll be the last time that happens for us during our careers. So not only for the payment reform process, but also we believe that it will be the basis upon which, or at least permit, some continued innovation. We have seen a lot happen over the last few years, and in particular accelerated because of the pandemic, when it comes to really innovation, stuff like telehealth, alternative destination, MIH. And we believe that without a solid foundation of data upon which to measure and understand not only the financial metrics of how EMS is delivered, but then other operational metrics that really it will set the foundation for continued innovation. In addition, for things like treatment in place, for telehealth, et cetera. We also believe that, again, in order to be able to continue to evolve, right? EMS is a relatively young profession, a young medical discipline, but just over 60 years, 50 to 60 years old at this point. In order for us to continue to evolve, really all things happen through data. So one of the things that we've been telling people it is critical that you and your organization engage, whether you are that first 50% that will be collecting data this year and reporting next year, or whether you are in the next group, because while we know that this currently is a 2-year process, most of us really fundamentally believe that this will continue in perpetuity. In other words, that we will be reporting data more often than just these next 2 years. We haven't heard that, but that's what we think will happen. In addition to that, I don't want people to think of this as something that's a negative. Truthfully, there's an old Deming saying, I believe it's Deming, who said, if data is like trash, if you're going to collect it, you sure as heck better know what people are going to do with it. And one of the things that we are entertaining is, that while we do fundamentally believe, based upon prior studies that the AAA has funded and or prior GAO reports, we do believe that we're underfunded. It is entirely possible, based upon whatever data gets submitted, that that data may not support that narrative, or that maybe the data that they come up with says that we're underfunded, but only by 1 or 2%, when we think, in fact, the data that we might collect through Amber suggests that we're underfunded by 15, 20, 25%. So what we say is, this is both what we believe a defensive, an offensive, and a defensive strategy. So it's important that you engage, and not that you just, we've heard from folks, geez, I may not do it because the 10% penalty that I will suffer as a result of not reporting my data is probably less than it's going to cost me to actually do the cost collection. What I would say to folks are, recognize not only, number one, we've been screaming from the rooftop for money now for years. If we have a very low engagement on cost collection, the message back to CMS will be, that's okay, we get plenty, we don't need any more. It won't be the one that we would say, which is, we're too busy doing this, we don't have time for this. It'll be, nope, we get all the money we need. They will say also, we extended you this opportunity to give us your data, but you chose not to engage. The other thing I'll say to folks is, if you don't engage and understand that not only will you get that 10%, but if in fact the data results in a lower reimbursement or a new distribution of reimbursement, so it may not be 2, 3, and 22.6, it may be some wildly different number that actually isn't reflective of what it costs people to provide service. So we say to you, it's critical that you engage. And for every one of you on this webinar, you're probably not the issue. It's all of the others that you know of who don't engage. Please get them engaged. We know that what we are hoping that cost data collection, or the ground ambulance data collection process, will do is solve a whole bunch of challenges for us as an organization, or as a profession. We know that we have these below cost reimbursements. We know that there is a lack or a misunderstanding of the value that EMS plays in the whole total healthcare continuum. We recognize and believe that actually, while hospitals get some payments for serving underserved or unrecognized sort of safety net providers. We believe that this data collection process may help articulate that in a way that's more meaningful to say, geez, at the end of the day, if somebody calls, regardless of their ability to pay, we have to respond, show up, and transport, provide care. And we're not getting any payment for that. So what I would suggest is, I think that through this process that we will be able to demonstrate that. We also believe, again, that this will more highly recognize that, geez, the costs for providing services have dramatically increased, and that, that there should be a recognition for maybe things such as high cost drugs or other unfunded mandates, like when the stretcher thing happened, or, with the new track system, or some of the other requirements that we see out there. So we're hopeful for that, and we are hopeful that the data collection will allow us to be able to move that process along. So as I said, what happens if your agency does not report? Well, there's a bunch of things that will happen. Number one, you will receive a 10% reduction in all Medicare reimbursements for the following calendar year. So if you were supposed to report your data from 22 and 23 and you fail to, for 24, you will see a 10% reduction in all Medicare monies. Not only that, you will also potentially, the lack of engagement by this industry may result in those Medicare add-ons going away. It could decrease the overall fee schedule, and as well, any gains that we may have made with the various lawmakers and regulators around this country about the value that EMS provides will likely, in my opinion, very much be lost. So the collection timeline, we know that it used to be 1/4 of the industry or 1/4 of the services that billed Medicare each year over a 4-year period, collecting in either the calendar or fiscal year, and then reporting 5 months after the end of either the calendar or fiscal year. They have now, because of the pandemic, broken that down into 2 groups. 50% will collect data either calendar or fiscal year 22, reporting 5 months later. The other 50%, so if you were not on the list that was picked in years 1 and 2, which were that first 2 quarters, which are now the first group, you are on the list for the second group. So if you aren't collecting data in 22, reporting in 23, you will be collecting data in 23 for reporting in 24. Now, there is a report going, MedPAC that MedPAC's going to make to Congress following this. Now, this has been delayed, partly because of the whole cost data collection. That's a good thing, right? Because even on the original timeline, what we were looking at was very likely that a report was going to Congress that had very incomplete, if any, real data. So the delay is a good thing. So you're not alone. There's a whole bunch of resources that not only, I have to give CMS credit, they have done an amazing job, really, really good job at getting educational content out there, engaging the industry. The challenge is, while you can show up, if the agencies don't, there's not a lot that CMS can do about that. If you go to the ambulance resources page for CMS, you will find a ton of resources around the Ambulance Services Center. You will find a ton of resources around ambulance cost collection. You will find pre-recorded webinars. You will find a bunch of FAQs. You'll find a bunch of slides from those webinars. Additionally, you can go to the American Ambulance Association's page, and you can go to the cost collection page for the American Ambulance Association, and you will find all of our resources. Again, we have been working with this material now for nearly 4 to 5 years. I think it's actually 5 years at this point. And so what you can find there, of course, are the free newsletter. You will find the ability to email any, the cost collection faculty so that you can get answers to your questions. You will find the Amber, which is the cost collection software that the AAA had designed. I believe Aaron, director, will be doing a demo of that later on. Plenty of on-demand webinars, the ability for you to request. We are getting tons and tons of requests to come and present to different associations, different groups around the country, which we are. Sam, thankfully, has been quarterbacking most of that. And then, of course, your organization, much as you were doing today, but if you decide that you would like a workshop specifically, then you can certainly send in a form to request a workshop. We are doing, coming up this September, which is earlier this year, the AAA's annual conference and trade show will be in Nashville. Normally, we are in November, but this year it is a couple of months earlier. We are going to be doing a couple of workshops there, some of them intensive. Michelle and I will be doing a rural based EMS service intensive session. So if you haven't already done so, make sure that you register for that. But certainly if your organization or you folks, or if anyone you know wants to host a workshop or some other content, again, rising tide will raise all boats. If folks do not engage in this process, we are going to all pay the price, because keep in mind, we'll be judged by the worst of the data. If the only people who report data are those who either make it up or those who potentially have entire departments that do cost or are very data driven, that isn't necessarily going to be reflective of every ambulance provider. Those small rural services, 85% bill less than 2,500 trips to Medicare a year, 75% bill less than 1,000. So, or 1,500. As I said, CMS resources page, anywhere in this slide deck, I believe, and Sam can correct me, that you see under a link or a place for download, I believe you can click on that. If not, go to the AAA's webpage or just type in CMS Ambulance Service Center and this will come up. They have a ton of information. Just make sure, as you can see here, that you have the most recent version. All right, you will see a date next to it. Just make sure you have the most recent version. The most recent version, proposed version of the tool is from July of 2022, I believe that's the date. So I'm going to be handing it off in just a moment. The way you are going to be selected, just so you know, is by your MPI. Now, the cost collection tool is going to be an electronic tool. AAA hired a software development firm to create Amber because, number one, we know that as you're submitting your information to Amber, that certainly as the government's website, we wanted you to have an opportunity to be able to utilize a software that you could start to collect that information and verify that information prior to submitting it to CMS, to the government. As I said, data's like trash, we're going to collect it. Sure as heck better know what they're going to do with it. Amber is an opportunity for the AAA. Now there's a firewall between the AAA and your data. We will not be able to see anybody's data, but we will have the data in a de-identified, aggregated way. This is an opportunity. This software is available and free to any organization. You can just go to the AAA's webpage to find out how to access it. But this is an opportunity based upon the cost collection tool to be able to enter your data into a system and start to verify and validate your data. There is built-in error checking, so that if in fact you have data that doesn't make sense, the error checking will alert you to that fact. And we've learned that there is some of that in the CMS tool, but we have built in a whole bunch of that into Amber because we know, or we believe, this is a potentially a process that is going to be wrought with potential for problems. Now, again, the only thing worse than not reporting will be reporting garbage data. So it's really, really important that it's done and done right. There are a whole bunch of common areas for confusion with this. And one of the things that we say to folks are some of the common areas that we hear on a regular basis are things, for example, as part of the tool, what CMS wants to know is they collect information on your labor, or they want you to take a snapshot of your personnel at the beginning of the collection period. So if Scott works for you as an EMT in January of 2022, which is the beginning of your collection period, and in March, I become a paramedic, you're to report all of my information. We'll cover this when we get to labor as an EMT, even though partway through the year I changed. So they want you to take a snapshot of your staff at the beginning of the period. If somebody starts with your organization during the period, where at whatever position they start with you as is where you're going to tack them to as you go through collecting their hours and their wages. Understanding that if many organizations don't have, anybody who is working for the company, whether they're a chief, an administrator, maybe a treasurer, whatever that is, if that person at any point during the calendar year does an ambulance transport or responds to an ambulance call, that person is going to have all of their wages and their compensation and their hours reported as an EMT responder. So in some organizations, such as my fire department, every single person in the organization will be reported as EMT responder. Okay, CMS will know that there must be individuals who perform these administrative functions, but they must also be responders. They want to make sure that you understand if the person responded to one ambulance call, that person's going to be categorized as an EMT or a first responder. Total time on task and your response times. This can be an area that's a problem. For organizations where I used to work, you could be into Boston in 15 or 20 minutes. But there are places in this country where they transport 90 minutes to the closest, interventional cath lab or definitive stroke center. And when they call clear, they're actually not in their area ready to take another call. So it's important to know if you are in an organization where you have these long transport times where just having your crew call clear, but if no one's tracking that deadhead time to get back to your service area, your total time on task will be the time from when the call was initiated to when the crew is back in your service area and ready to respond to another call. So if your system isn't set up to do that and capture that now, you want to make sure that not only your policy and your CAD can do that, or your computer-aided dispatch system, but also the practice in your dispatch center is such that, hey, if I transported from Missouri into Nebraska to a stroke center and they call clear, that I don't actually, their time on task is counted until they're back into my district and able to respond. And then the last piece is, if you are a shared expense organization, so you're a hospital-based EMS system, you're a fire-based EMS system, some other, whether you're possibly in air and ground, we don't want air in this instance, but we do want ground. And those expenses are shared by, let's say you're a municipal-based system and the town has an HR person who or you're part of the town's retirement plan. You're going to need to get that information and make sure that you're getting the associated cost or expenses related to those items, because what we're looking for is we're looking to make sure that you have that we're accurately capturing all of the costs related. Because if I'm a town, that all of my HR and all of my administrative costs are picked up by the town and not directly affiliated with my fire department, then my costs are going to look substantially lower. It is not in our best interest to have costs looking substantially lower than they actually are. It's in our best interest to have costs looking exactly as they are. So with that, I can take a breath. I'm going to pass it off to my colleague, Michelle, to let her run you through the next few slides.
Great, thank you, Scott. So we'll just go through a few different pieces that will be coming up. So the ambulance data collection instrument is broken into 13 sections, just like the CMS instrument is. So as we go through this course, we're going to actually go through all of those 13 sections to give you all of the information you're going to need. All right, next slide, please. So the general survey instructions will ask you your NPI. So if you bill for multiple NPIs in the instrument, you'll need to specify the NPI that you're reporting on. It's expected to take about 20 hours to collect the data and 3 hours to review, submit, and make sure that everything's accurate. So for the purposes of this presentation, we use ground ambulance operation to refer to the NPI you're recording for. So your organization-specific data will be submitted, but as Scott said before, it will not actually be published. So your responses to the questions about organizational characteristics will set up the remaining questions you're asked. So once it asks you about those NPIs and ownership, the organization contacts, and whether you're reporting on a calendar or fiscal year, then you're going to go into description of what your ownership is. So a nonprofit, a for-profit, a government, or a private or public partnership. So when you answer those questions, we have a few highlighted here. And if you are in the highlighted area as it would pertain to your organization, the fire department, police or other public safety, or hospital or other Medicare provider of services, you'll make sure that you'll need to make sure that you are saying that you're going to share those services. So as you go through the tool, it's going to ask you if you have shared services. So make sure if you're one of the fire department, police, or public safety, hospital, or other Medicare provider services, that you say yes, that you share services. So some of the other organizational characteristics they'll be asking will be about those shared services. If you provide air ambulance, do you have volunteers? Are you a 911, a non-emergency ambulance transporting agency, or both? Your hours of operation, or your paramedic intercepts, which is only for New York. As you read through the printable CMS tool, you'll see they have notes about skip logic. So this means that they're going to hide questions that are not relevant to your service, and they'll give you the questions that are relevant to your service. So make sure that you're answering those questions accurately as you go through the tool. So it's going to show warnings and additional questions based on your answers in the previous section. And Amber has that exact same skip logic. So as you're going through the Amber tool, it's going to drag you through that same skip logic. So make sure that you're accurate in answering those questions. So all the costs are collected and reported by categories, so different buckets. The total of these categories equals your ground ambulance costs, things like labor, facility, vehicle, equipment and supplies, and other costs. We'll be walking you through the different categories and explain them more in detail throughout this presentation. For some services, they'll be out of scope costs. In other words, the total costs that are going to equal more than the ambulance only costs. Some of the out of scope costs will be for fire or police based ground ambulance operations. So anyone who provides air ambulance services along with ground ambulance operations, and anyone who provides healthcare outside their services, that is not ground ambulance only. Fundraising is another area that is out of scope. And they will ask specific questions to parse out this data. I'm going to pass it along to Scott.
Yep. So, it's always fun when one person's controlling the slides and someone else is talking. You want to get to that point where they don't have to say next slide, but then you don't hit the button too quickly. So, all right, we're going to continue to work our way through. So one of the, after you get through the organizational characteristics, and understand that is the setting you up for the rest of the tool. So if you see a question that talks about being a public safety agency, but you are not, you have answered something wrong and you need to go back and fix that. So that is the idea behind skip logic. Same thing exists, by the way, in Amber. So when we get to the service area and response times, this is where CMS is really trying to get a fundamental understanding of besides what kind of organization are you in, what's your geographic region look like? The old saying in EMS that if you've seen one EMS system, you've seen one EMS system. As you travel about the country, in my area up here in the Boston area, we have 4 trauma centers, 4 interventional cath labs within 15 minutes of any place that I ever worked. When I went out to Missouri and was out there riding along with them, their closest interventional cath lab was 90 minutes away, right? So again, depending upon where you are, there are geographic factors. There are other factors that are going to impact your cost, because again, if I can do a call and turn it around in 75 minutes and somebody else, it takes 3 hours for a call, that comes back to your cost. So first, they're going to want to know what areas are your primary service areas, and that's the area in which you are exclusively or primarily responsible for providing service at one or more levels, and where it is highly likely that the majority of your transport pickups will occur. Now, that can be, just so you know, you may exclusively own a particular zip code or area. For example, if you provide the 911 service or the service to a particular county, in the tool, you're going to be selecting what we believe you're going to be selecting zip codes. So you're going to need to have the zip codes for that. Now, in the Amber tool, you can draw a map and it will automatically populate those. You can select multiple zip codes. Again, primary service area, it's entirely possible, depending if you're in Pittsburgh, for example, there may be the fire department, but also many private organizations or other organizations in the city of Boston. Not only does Boston EMS cover Boston, but so do a whole bunch of other private services. So it is okay if 2 ambulance providers happen to identify one zip code as their primary area. That's perfectly fine. All right. But it's just important you understand is you're trying to answer for you. So it's wherever roughly 50 0.1% of your transports occur, that would be your primary service area. Now, your secondary service area is the area outside of that primary area, but it's one where you are regularly providing services. The key here is through mutual aid or auto aid arrangements. All right. So they don't want areas where, for example, you got activated as a result of a regional event. Let's say your state activated you to move and go to a place because of a flood or a hurricane, or you went to Louisiana during what, you know, activated through the FEMA contract and sent down to Louisiana or Texas for hurricanes. They are really looking for, hey, it's outside of your primary area, but where you do go from time to time to do transports because you've said through mutual aid or through some auto aid arrangement that you're going to respond to those calls. This again gets at, what does it cost you to provide service? What's the environment upon which you're providing ambulance responses? And what's your area? Because as you cover a larger area, your costs are going to go up. Now, you will select, this is going to be by your, this will be by your NPI. So Amber has a really cool tool in it where you can either click an entire county, you can click individual cities, or you can just draw a map as to what is your primary and or secondary area, and it will automatically populate that with zip codes. So it's actually a pretty neat feature, but the idea again is to make sure that I know what geographic region that you're covering. So service area and response time. So after we get by the service area and response times, what we get to is then, okay, what's your average trip time? And this goes back to what I was mentioning on the frequent areas of confusion. So they're looking for your average trip time across all service levels, ALS, BLS, or if you have advanced, however, in your primary service area. And they define that as the time when your organization begins its response to when the ambulance is available to take another call. Now, if you don't define it that way, let's say in your organization you use a 90th percent, some other definition, they're going to ask you what that is, and then you will provide that average trip time. They want that for both your primary, and then they're going to ask for that in your secondary service area as well, trying to understand what is your average trip time. So in the example I used earlier, if I'm Scott working just in the Metro Boston area and I transport to the Mass General, my time on task is likely to be 45 to 60 minutes. If I'm working in rural Missouri and I transport to Nebraska, we're talking about an average trip time of probably 3 hours. That goes to cost. And as a result, CMS wants to make sure they capture that so that as they reform the payment system, again, it's in our best interest to make sure we have those numbers as we reform the payment system, that they can consider that. Now, they're going to ask you more specifically. So the last one was your total time. Now they're going to ask you about your response times. And that is, as they define it, it's the time from when the call comes into your dispatch to when the ambulance or another EMS response vehicle arrives on scene. Now that's your EMS response vehicle. You're not responsible for tracking when from another agency or another entity shows up. All right. So they have a couple of definitions for this as well. You can use it from the time the ambulance leaves the station. So if you don't know when the call came in, but you only have from when the time the ambulance leaves the station, that's fine. What I would suggest to you is if you can get the number, then get it. All right. So the more specific you can be, the better off, I think, the more accurate your data will be. It also could be from the time the organization receives a call from the dispatch to the time the ambulance or other EMS vehicle arrives on scene. Now, they are going to ask you if your organization is subject to any response time initiative or penalty, right? Same thing, just worded differently. So they're going to ask you, is there a response time initiative or penalty? If so, who establishes that response time or penalty? Is it your organization who internally has decided we will respond to every call within the famous 8 minutes and 59 seconds? If that's an internal factor, well, that's a factor you've decided, and it's not externally determined. Like, for example, where you contract with the municipality and you promise a response time of 8 minutes and 59 seconds. And if you don't meet that 8 minutes and 59 seconds, X percentage of time, we're going to penalize you. Well, they want to know that. Not only does that go towards cost, but it also goes towards time on task and the amount of resources that you're going to put there. So they will ask you who determines it. And if you don't, again, if you're reporting these additional costs because you're paying penalties, which many agencies do, CMS just wants to know that. So again, keep in mind what we are trying to do is get to the cost issue. So I'm going to pass it over to Mr. Werfel to take us through ground ambulance service volume. Brian?
Thank you, Scott. And before I turn to that, just to go back to the previous slide, there was a clarification in the proposed rule that did come out last month, which, while not final, will likely be finalized. And it goes to that issue of the penalties. And specifically, what they clarified is that they are thinking in terms of actual financial penalties as opposed to some other form of penalty, right? So basically, in answering that question, it would mean if you're subject to fines or monetary penalties for failing to meet some agreed upon response time. So, okay. Moving on to ground ambulance service volume, section 5 of the data collection instrument is where we start to get into the volume of responses that your agency provides. So among other things, what they're going to ask for is the total number of responses that you provide every year. And that is defined to be the total number of instances in which you respond, whether or not you're responding with a ground ambulance, and irrespective of whether or not the patient is ultimately transported. They will then include subcategories, if you want to think about it that way. So a subset of total responses are total ground ambulance responses. So these are those responses where you dispatched an ambulance, again, whether or not you transport the patient and whether or not that transport is ultimately paid for. One thing to keep in mind here is in situations where you dispatch multiple ambulances to a particular incident. So for instance, a motor vehicle accident, you may send multiple ambulances. You should only count that response with multiple vehicles as a single response. So it's those incidents in which you dispatch one or more ground ambulances, right? They will then ask you for a subset of your ground ambulance responses to provide information on the total number of actual ground ambulance transports you provide. They're getting at medically necessary transports, but anytime we load the patient into the vehicle, it's likely going to be counted as a ground ambulance transport. And then separately, they're going to ask you of those ground ambulance transports, what percentage of them were paid either in full or in part. And here we get into another clarification they've made since the first publication of the data collection instrument. And it goes to the timing. They recognize that there is a time lag between when a transport is provided, when a claim is submitted to the payer, when it's ultimately adjudicated and potentially paid by the payer. So what they're looking for is, as of the date you're submitting your report, those responses that occurred in the data collection period. So for those of you that are using a calendar year, that's the 2022 calendar year, you'll presumably be reporting sometime in 2023. So what they're really asking is, on the date you submit your report in 2023, tell me about those transports that occurred in 2022 that were paid in full or in part. So if a transport occurred in 2021 but didn't get paid until 2022, we do not count that, right? If a transport occurred in 2023, in the example where we're using our 2022 data, we don't count that either. So the data collection period indicates when the ground ambulance transport occurred. We then look to whether or not it's paid based on the lag between the end of that reporting period, the collection period, and when the report is due. So I realize that that's somewhat confusing, but there is two different periods that you will see referenced. The data collection period is the 12 consecutive calendar month period that you're reporting your data on. The reporting period is the window in which you have to submit the report after the end of the data collection period. So you may hear those terms thrown around. All right, Scott, can we advance forward one, please? Thank you. All right, so in situations where you intercept with another agency and either you are the transporting agency, perhaps you're operating at the BLS level and you're intercepting with a paramedic service, or perhaps you're the ALS service intercepting with a BLS service that is ultimately the one providing the transport, they're going to ask about those joint response situations. What they're going to ask is, do you ever respond with a transporting vehicle intercepting with another non-transporting agency, for instance, a local fire department? And then they're going to ask what your best estimate is of the total number of your responses, ambulance responses, excuse me, where there is another entity involved. So again, this is a best estimate. If you don't have exact figures, that's fine. Just do the best you can here. They're also going to ask what percentage of your ground ambulance responses occur in your primary service area versus your secondary service area. The way it is phrased is to ask for your estimate of the percent of your total ground ambulance responses where you are responding in one of those secondary service areas. And then they're also going to ask for an estimate of the total number of ground ambulance responses that do not result in a transport. In theory, that number could be derived from the delta between your total response, ground ambulance responses, and your total ground ambulance transports. And then okay. So as a check, you can always just make sure that your total number of non-transports plus your total number of transports should equal your total number of ground ambulance responses. Next slide, please, Scott. Okay, now they're going to ask about certain other situations. So they're going to ask whether or not you provide standby EMS services, situations where, for instance, you're asked to provide a vehicle to an event. It could be a high school football game, a local concert, sporting event, etc. Right? Again, the concept here is that this is a drain on resources and that you are incurring costs. They will separately ask you whether or not you're paid for them in the revenue section, but for now, they're just asking whether or not you do provide standby services. They're also going to ask about paramedic intercepts and ALS joint responses. And here we need to be a little careful with our terminology. In the Medicare world, a joint response is a situation where you jointly respond with another EMS agency, regardless of the level of service you are providing, as opposed to the level of service the other entity is providing, meaning you can both respond at the ALS level, you can both respond at the BLS level, one of you can respond at the ALS level or the BLS level, right? That is a joint response in Medicare's world. The paramedic intercept in Medicare's world has a very precise definition. Unfortunately, that definition, unfortunately, that same term, a paramedic intercept, is used to describe a much broader situation colloquially in our industry. In Pennsylvania, when you respond with another entity, even if you are providing a ground ambulance BLS transport and they are providing an ALS paramedic, you are providing a joint response. The paramedic intercept in Medicare's world is a very specific situation where you are providing ALS services in conjunction with a volunteer BLS transporting agency in a rural area, and where that rural volunteer BLS entity, the one that does the transport, is prohibited by local law from billing for its services. To my knowledge, this only exists in upstate New York. So therefore, in Pennsylvania, the answer should be simple. You provide no paramedic intercepts. So that one just answers 0. All of the other joint response situations would be listed as the joint responses. So, all right, moving on. I think I'm responsible for this one, but Scott, correct me if I'm wrong. If not, I'm going to take it. They're going to ask for the service mix. So what they're going to want is for you to break down whether or not you're, the relative volume of services that are provided at the emergent versus non-emergent level, and the ALS, BLS, ALS2, or SCT levels, etc. And here we should be using Medicare's definitions, even if other payers may have their own definitions that may overlap in some way. So one easy way to do this, and just to pull it out of your billing system, is to just pull it based on the HCPCS codes that are specific to each of these levels of service, right? Keep in mind, again, that the total number of emergent and non-emergent responses that you provide should equal 100% of your responses, right? I think if we advance one, okay. And in terms of how they're going to ask you to break it down, they're going to ask you to break it down by percentages. So again, this should total 100%, but based on those HCPCS codes and based on knowing the total volume, you would simply enter the total percentage of each of the various HCPCS codes as a percentage of the total volume. It will also ask you a derivative question that asks what percentage of these transports are inter-facility. Unfortunately, they haven't really clarified what they mean by a facility in this context. We are fairly certain that hospital to hospital transfers are considered inter-facility. Where things get a little less clear is when we get into the nursing home space. So using Medicare's definition for SCT, it is safe to assume that skilled nursing facilities are considered facilities, and therefore between two nursing homes or between a nursing home and a hospital should likely be counted as an inter-facility trip. It's a lot less clear when we get into some other sorts of custodial facilities. But again, this is a best estimate here. Don't make yourself nuts trying to get this percentage to the exact number. For those of you that can run reports based on modifiers, that's probably the easiest way to do this, right? Just set the parameters based on, N to H, H to H, et cetera, and pull out that total volume, and that should become the percentage, right? Let's advance one, Scott, and I think it's labor, in which point I'm going to turn it back to you.
Yep. Thank you. Thank you so much. So the labor section sort of is without question really the meatiest part of the entire tool. There is a pretty lengthy, and I think it also has the lengthiest set of instructions. So if you haven't already done so, you haven't downloaded the paper version of the tool from the CMS Services Center. You can also access it through the AAA's website. You'll see in the tool, it's a little bit hard to read because of their attempts to show the skip logic, which are in the sort of bolded bracketed areas. It becomes a little bit more difficult, but sometimes it's easy to, if you can have that document as you're reading through not only either our presentations, this presentation, or the ones performed by CMS. So this is the largest section of the tool, and what they're looking for when it comes to recording labor is those folks who are either partially or entirely related to ground ambulance operations. So if you are a standalone EMS organization, all your organization does is EMS, then that will be everybody at your organization. If you are a fire, hospital-based, or an air service, then that is where you will be having to go through and do some calculations. And to the extent that you're able to identify those folks who have nothing to do with the ground ambulance, well, then you won't be reporting their labor here. But for those who have partial responsibilities, you're going to need to the extent possible, be able to allocate that number of, not only they're looking for compensation, total compensation, which we'll talk about what that is in a minute, and they're also looking for total hours. So they're not looking for anyone who's a contractor. So if you have any contract labor For example, you have a contract medical director, or let's say, for example, you have a service that you contract with to come in and do groundskeeping or fleet maintenance, whatever that might be. If you have a group that you issue a 1099 to, generally we're not looking for those. They're looking for folks that you issue a W-2, or if they're volunteer, those folks who are acting in a volunteer capacity, either entirely or partially related to ground ambulance. Labor is divided into 3 categories. All right, that is EMT response staff. That is any individual who has responded to at least one ambulance response throughout the course of the data collection period. So that could be your EMTs, your paramedics, but in many of the smaller organizations, even the service director or the person who's doing payroll, HR, scheduling, whatever it is, those folks, if they at some point or another got pulled to go respond to one ambulance call, or they did respond to one ambulance call, not because they were pulled, but they just decided to, then all of their labor and all of their hours will be recorded under the EMT response staff. Now, if you have folks who at no point during the reporting period, in other words, let's say, for example, it's someone who does payroll or someone who does HR or someone who does education, and at no part did they respond to an ambulance call, those folks will be in that second category, the admin or facility staff. This can include folks who run dispatch, folks who do fleet maintenance, HR, education, payroll. It really could be your CEO, COO, your administrative director, whatever that is. But if that individual at one point during the reporting period responded to an ambulance call, then that their labor will be reported in category 1. The last category is the medical director. In this instance, I'm not looking, if you have an affiliate medical agreement and an agreement with an affiliate hospital to provide medical direction and oversight to your staff, and that is paid through a contract, that I don't want them reported in section 7. They will be reported in a later section of other costs, okay? Only looking for people who are employed by the organization or who volunteer for the organization in this section, all right? Early in the tool, there is a question up in the beginning section about, do you use volunteer labor? They said specifically they put this question in there just to make sure that those organizations that utilize volunteer labor understand that they have an obligation to respond to the tool. This is right from the CMS, one of the CMS presentations that they did back on February 6th in 2020. As I said, I think they did a very good job working not only with the CMS staff, but the RAND group, who have been pretty intimately involved with this whole ground ambulance collection process. They have what really is, we in EMS, we love algorithms. So they have this really put together, this really nice algorithm that helps you understand what category those folks fall into. So did you have a person or did the person have ground ambulance responsibilities at your organization during the data collection period? If the answer is no, well, then you're not reporting their compensation and hours in the tool. If the answer is yes, you have to answer the next question, which was the person a paid employee of your organization at any point during the data collection period? If the answer is yes, so in other words, let's say they were a volunteer for part of the year, and then they became paid later in the year, you will report them under the paid category, all of their stuff under the paid category, all right? If they were not paid, they would fall into the volunteer category. Then if you say yes, so if you say yes, you include those people in that category. Did that person have EMS response capabilities or obligations during the data collection period? So did they respond to a call? If the answer is yes, then they are going to fall into one of these categories. If the answer is no, they will fall into those, either the medical director or the admin facility. If they were volunteer, you're going to answer that same question. So again, it's important that you put these people in the right section, because if you don't, right, for example, if you say that if you under or misreport, it is going to skew your numbers in a way that will make it not accurate. It is in our best interest to have this information as accurate as possible. Do not spitball if you can avoid it. All right. There is a checklist. So each member, right, should contribute to only one category. I do not want you allocating and CMS said they do not want people allocating, just like with volunteer labor. They don't want you to impute a value or dollar figure for that volunteer labor. They're saying that they will take care of that by using data submitted by organizations of like size and like geographic regions based upon zip code and whether what metropolitan area they're in, et cetera. They're going to go through and they will impute a value on the backside when they're doing the data analysis. So if you have a staff member who is a basic EMT, but who also performs administrative capabilities or duties, you're going to have that person reported in the paid basic. If you had a paramedic who did some additional unpaid hours, right? Let's say they are a paramedic, but then they volunteer to do some other like people can't volunteer for the job that they get paid for, but let's say they volunteer to go out and fundraise for the organization. All right, that person's going to get reported and paid. If you have a paid administrator handling billing or clerical duties and occasional vehicle maintenance, all of their stuff will be put into the administrative/facilities category. If you have a volunteer who became a volunteer paramedic during the data collection period, then you're going to put them in the volunteer. So this is really something that's intended to make sure as you go through that if you're uncertain, for the majority of our folks, probably 95% of the folks in your staff, you're going to very easily be able to categorize where they land on this, what bucket they end up in. Again, the goal is to make sure that we're analyzing like information, apples to apples and oranges to oranges. Now, there is a checklist that you will fill out in the tool. This, again, sets up, if you're an organization that has no paramedics in your organization, when you check off that you have basics and you don't have any paramedics or intermediates or doctors or EMRs or licensed ambulance drivers, don't take offense to that. There are places in the country where people are licensed ambulance drivers. Then you will only see questions tied to basic EMTs. But here is where it will ask you, do you have paid staff without fire responsibilities or public safety responsibilities? Yes or no. As you click that off, that will set the questions up for the rest of the section. They will ask you if you have volunteer staff who do not have any fire or public safety responsibilities. Then they will say, hey, do you have staff who do have public safety responsibilities in addition to their ground ambulance work? And then volunteers who do have it as well. Again, the idea is to make sure that we're getting who works at your organization or volunteers at your organization, and ensuring that they are appropriately, they're putting you in a bucket to analyze the data in the correct way. Now, they'll do the exact same thing for those folks in the administrative staff category, but they will break them down. Do you have administrative folks, people who are doing clerical work, HR, billing, IT? They will then go down and ask about management folks as well. And by the way, though, if any of these people responded to a ground ambulance call, they don't belong in the administrative category. All right, let's be clear. So if on any point in the 12-month period or the 365 days of the data collection period, they responded to one ground ambulance call, they go in that first section, EMT response staff. Okay. They're going to ask, do you have dispatchers without public safety roles, facility maintenance people who had no public safety roles, and then other folks who aren't reported above? You just need to list who those are. We'll do the same thing for volunteers, and then those who might be a paid staff who had public safety responsibilities or volunteer who had public safety responsibilities. Then as we go through or on in the tool, and as I said, this can be pretty beefy. Now, keep in mind, in the instructions to the whole thing, CMS said, we think this will take you about 20 hours to do. I think that's probably a lot of nonsense. Now, it could be done if, in fact, you've done your homework and you've prepared your system to make sure that you can do that. This is a time in which I would strongly suggest, if you haven't already done so, hopefully you have, but if you haven't already done so, go into your scheduling systems and make sure that your systems are set up to make sure that people are categorized correctly and that you can easily pull this information out. In many of the different data systems that we've looked at over the years, they will have places for accounting codes or export codes. This might be a place where you'd want to make sure that you've set your system up to make this easy to do. Again, I do not believe this will be a one-year thing. I don't think if you report in year one, you won't be reporting in year two unless you have 2 NPIs. But I think after this data collection period is done, in other words, after the report goes to MedPAC, my gut is we're probably going to see this as an ongoing collection process. They are going to ask you again, what was the total annual compensation? And I'll talk about what that is in a second. And then they're going to ask for the total hours worked for paid staff. Then of that, they're going to ask, all right, what was related to ground ambulance service? Total hours worked annually to public safety. So in other words, if we were adding those hours up, they should equal the total number of hours for all individuals that work in your organization. All right, so this should be pretty straightforward. Dollars and hours, and then what number of those hours were related to ground ambulance operations. All right, this you should be able to pull right out of your payroll system. You should be able to pull right out of your scheduling system. Just keep in mind, and we'll get to volunteers in a second, that if you are a volunteer agency, many volunteer agencies don't track time. You are going to need to start tracking time. Now, what are we including in compensation? CMS has been very clear. They want any salary, wages, overtime, training time, standby time. It can include payroll tax. That's up to you. But if you include it here in wages, don't include it somewhere else in other expenses. Okay. That's an important piece for this whole process. Only report a cost in one location. The compensation is going to include any costs related to healthcare, PTO, retirement, stipends, life insurance. If in fact, let's say you're a municipal agency and your folks are getting their retirement and benefits through the city or the town benefit or retirement plan, you're going to need to go out to your city hall or town hall and ask them for the costs associated with those benefits, because they are included in compensation and you are going to need to report them. Most people, if you happen to be using a payroll software or system, even something as simple as QuickBooks, you should be able to pull this out. Now, if you're manually doing your stuff, this is going to involve some tracking of time. You are then going to go through and do the exact same thing for those labor costs for your administrative and facilities folks by individual category of groups. So administrative facility staff without any public safety obligation. What was their annual compensation paid for administrative safety / medical directors? All right, you'll go through compensation, hours, and then the total number of hours worked annually related to ground ambulance, the total hours worked annually related to fire, police, public safety. Now, it's my belief that if you answer that you don't do any public fire, police, or public safety, that these columns should not appear, or they will black out and not gray out, and they will not let you put anything in. If these are appearing and you're not a public safety organization, my belief is you have done something wrong or earlier in the tool. So for public safety organizations, it's just a little bit differently. All right. They're going to ask, in some organizations, they have EMT basics who have no, really the ambulance folks work the ambulance, the fire folks work, they work fire and not. So they're going to ask for you to break that compensation down for those folks. Those who, if they don't have any fire public safety role, they just work on the ambulance, which is pretty uncommon, I think, but it just work on the ambulance. You're going to report their compensation, their hours, and then the hours worked annually related to ground ambulance. Now, for a person without any fire public safety role, that should be 100% of their hours, unless, let's say, they're doing other stuff, education or something else. But generally speaking, this should be pretty straightforward. You're going to do that for all of those categories. Now, here on volunteer labor, this gets a little trickier. You won't be reporting any wages because volunteers by nature don't get paid a wage. If you are paying some kind of stipend or other compensation, you're going to, or other cost related, that's going to be a cost, not a wage. That's going to be reported in a different section of the tool. So here you are going to need to track their hours. Now, I've heard from a lot of volunteer agencies around the country that, geez, we don't track any hours. Sometimes we don't even necessarily know who showed up on the call. There's a whole reason for why that's bad. And you are going to need to know for infectious disease rules and all that. You're going to want to know who was there, when they were there, and why they were there. So for volunteer hours, you're going to need to have a process by which you can understand and track how many hours they worked. You do not want for the federal government to presume or to underreport the number of volunteer hours, because again, that goes towards cost. In this instance, volunteers, there is a cost to volunteer labor. It's just in this instance, your volunteer is paying for that cost, right, with their donation. So you're going to need to track what was those total hours for all EMT response staff by category, total hours worked annually related to ground ambulance, total hours worked annually related to the public safety role, and then the total hours worked related to other responsibilities. That could be the education, et cetera. All right. Now, volunteer hours, they want to make sure that you understand, right, that all hours worked, for total hours worked annually related to ground ambulance, those worked for, total related to fire, public safety, others, and that, and that you're just recognizing that if I'm not looking to capture per se those hours that are unrelated, so air ambulance operations, healthcare delivery, unrelated to ground completely. So if you got them working in the hospital ED, or you've got them working in a clinic somewhere, some other public health or safety responsibility, community outreach, if I'm out doing CPR programs, that's not related to the provision of ground ambulance services. And so they're not looking for that information. All right. They're not looking, when it comes to volunteers, for time spent on call per se. So if I've agreed to hang around my community, I was a call firefighter, those weren't hours worked. I was free to do what I wanted with my time. I just had agreed that if the tone goes off, I'll go in. They're not looking to capture that time. They're looking to capture only the time actually worked. So from the time the tone goes off to the time the officer or the department calls all clear and those people can go. They're also not looking for time where you're out at the boot at the intersection collecting money on behalf of MDA or whoever you, or even for the actual agency itself. I know a lot of agencies do fundraising as a function of supporting their ambulance operation. Volunteer labor, they want to make sure how many individuals were administrative facility volunteers in the reporting period. And they want to make sure, again, if I haven't said it enough, just being clear, if somebody has EMT first response obligations, all right, they're not administrative labor. All right, what was the total number of hours worked by administrative volunteers during that year? If you have a volunteer medical director, many volunteer organizations do have a volunteer medical director, that there is a cost associated with that. If your medical director stopped volunteering and you had to go out and pay for it, you want to make sure that that cost, which in this instance, a volunteer medical director, if that cost is being absorbed by somebody else, not your agency. And did you provide, they're going to ask the questions, did you provide any stipends, honoraria, or benefits for volunteer labor? So some volunteer organizations might, for example, pay for your, like at my fire department, they paid for our recertification costs every single year. They also provided us with a ton of education, some of it related to fire, some of it related to EMS. So they're going to ask you, geez, did you provide any stipends? Let's say, did they give you a uniform stipend or something like that? They're just asking. That's a simple yes or no question. Now, in Amber, this is done. Generally, Amber tends to echo the tool. It may look a little bit different and be laid out just a little bit different. When we built Amber, understand the tool hadn't been published yet, or when we started building Amber. Now, and in some instances, while I think CMS did a nice job, I think Amber, frankly, is more intuitive. And, to be honest, had we known there would have been a 2-year delay, Amber would have been developed in a slightly different way. We would have worked Amber from a transactional perspective first, and then turned it into a reporting software. We started out with a reporting software because of the very short window of time between when the first group was going to report. We're now building that transactional side on the back end. So recognize that you will see this sort of breaks down for you what Amber looks like as it relates to those who have shared services. So
Booking.com helps you find and book
air and ground operation, as well as hospital-based where you might have medics working in the ED and on the ground ambulance or fire-based situations. And then those that are not shared, it is going to be pretty well broken out, right? You will not see the time unrelated to ground ambulance operations. So I've got a couple more slides, and then I'm going to hand it back off to Michelle. The facilities section, then these next two sections are actually pretty straightforward. And so in this facility section, what you're going to do is you are going to list all of your facilities. And by the way, we're going to have tons of time for questions at the end, I believe, based upon the time that we're tracking on right now. So again, if you have questions, you don't want to ask, more than likely, if you have a question, so does one of the other attendees. But if you don't feel comfortable, you can always send that into hello@ambulance.org, and it will get routed to one of us, and we will answer that question for you. But section 8 is about the facilities. In this instance, they're looking for how many facilities do you have? I only want those that are used entirely or partially related to ground ambulance services, right? So these will generally be your ambulance stations. It might be your maintenance bay, might be your billing department, your billing location. They are going to ask you to list those facilities. Once you list the facilities, that name will carry throughout the tools. Same thing will happen. Michelle, I'm guessing Michelle will probably talk about this when she hits the vehicles. So what they're going to ask you to list those. Once you list those, give it a name. You can list it building 1, 2, 3, or whatever the address location. My suggestion to you is use a name that in the event that someone has to report on this 2, 3, 5 years from now, that name remains relatively consistent. So if the station has a name or a number, use that. Then it's going to ask you, do you or does your organization or another entity pay rent or lease the facility? That's just to understand the nature of, is this a capital, is this rent that you pay, or do you own it? That goes to a financial calculation. Then they're going to ask you, if you or your organization, they're asking you to check off which applies. So did you pay rent? Did you pay a mortgage? Do you own the building outright? Or was that facility donated to your organization? And in that instance, you're going to exclude maintenance, utilities, so forth. They just want to know, what's the ownership status of this building? How are you using this building? It is then going to ask you for what the total square footage of the building is, and then what percentage of that square footage is related to ground ambulance service. So if you own a 10,000 square foot facility, but 1,000 square feet of that is retail or used by somebody else, then in this instance, you'd list that it's a 10,000 foot facility, but 99% of that facility is actually 90%, forgive my math, is used for ground ambulance services. So important that you have that. You can start to prepare. That should be pretty straightforward. If you're a municipal agency, you may need to go out and do some calculation based upon how that is. If it's really kind of too hard to break that down, another way that you could do it would be to take the percentage of calls that you did, the total call volume of your agency, and then what percentage of those calls were tied to ground ambulance. You could do that. What I would suggest is be as specific and as accurate as you can be. So again, total square footage, how's it owned, or how are you in that building? Why? You own it, you rent it, or you got to donate it, or you donate it, own, rent, or mortgage. And then what percentage of that square footage is used for ground ambulance? Now, as you get into that, it's going to ask you, all right, if you lease it, what are those costs, right? Is there any depreciation expense? Was there total acquisition cost? So as you go through, you're going to put in those amounts. Those names will populate, and so will, again, any information that you had put in previously in the tool. They're going to want to know what those costs are, or what you actually paid for those. They're going to ask this for those that you own. They're going to ask that for those that you lease. All right. And I believe, if I'm not mistaken, actually, no, one more. Insurance, maintenance, utilities, and taxes. All right. This is as it relates to the facilities that you own, rent, lease, or have donated to you. So it could be that they donate the facility, but you have to pay all the utilities, maintenance, insurance, etc. It could be that you lease the facility, but you have to pay all those maintenance costs. If your lease includes those maintenance costs, then just include those maintenance costs. And let's say, for example, you won't reflect any maintenance costs in here. If it includes utilities, you won't include those. You won't put those here if they're included in your rent. If it's, let's say, $1,000 a month, and that includes, all of your taxes, utilities, and maintenance, great. You report it in your rent. If it is broken out, then you'd record your rent and then those other amounts separately. So they are going to ask, what is your total facility related insurance cost for that reporting year? One of the changes that they've made to the tool, and we need to go back through and update these slides, is it no longer uses the term calendar year or fiscal year. It only uses reporting year, because in some instances, folks are on a fiscal year. In other instances, folks are using a calendar year. They're going to want to know, how much did you pay for those insurance costs? And again, what percentage was associated with the ground ambulance operation? So if you have a 10,000 square foot building, 1,000 of it's retail, and you're only paying your tenant is paying a portion of those costs, or you're paying those costs, I'm sorry, and that 10% of it is associated with your tenant. Well, then in this instance, again, those percentages would reflect here. Same with maintenance, for any maintenance improvement costs for that year. All right. In this instance, if you have maintenance costs and you have an in-house maintenance person that you recorded their labor in the labor section, don't record their labor here. Only record the costs of the repairs. Let's say, for example, parts, whatever, not labor. If you didn't record them here and you put them here, truthfully, it's more accurate to do it in the labor section, but just don't report it in two places. All right, same thing with utilities costs. And then, of course, your facilities taxes. They're going to want to know, how much did you pay and what percentage of that was affiliated with your ground ambulance operation. So with that, I'm going to hand it off over to Michelle to pick up with the vehicles.
Wonderful. Thanks, Scott. That is a big section of this tool for sure. So the next section that we're going to cover is vehicle costs. So we're going to go through they're going to go through and ask a whole bunch of questions about your vehicles. So how many ground ambulances does your organization own, including vehicles that have been purchased, gifted, or donated? So you'll enter that number in. And then how many of the ground ambulances does your organization lease? So you'll enter a number of how many you are leasing. What is the total number of miles, billed and unbilled? So if you're not recording miles right now, it's really important to go back and make sure that you're starting to record all of the miles that are driven by your vehicles. So it's either traveled by land ambulances for any reason in the reporting year. So if it goes in for maintenance, if it comes back from maintenance, all of the total miles that you have for those ambulances, you'll need to record. What's the total number of statute miles traveled by water ambulances for any reason during the reporting period? And then report the following information for all the owned and leased vehicles that your organization has. So if you calculate depreciation expense for multiple purposes. So for example, depreciation for tax incentive purposes versus generally accepted accounting principles, which is the GAAP. For standard auditing purposes, please just report the depreciation expense captured for those standard auditing purposes. For your owned vehicles, you'll answer these questions such as, did the vehicle transport patients during the reporting year? Was the vehicle donated? How much was the annual depreciation? Was the vehicle remounted during the reporting year? And what was the actual cost for that remount? So it'll take you through a bunch of these questions throughout the tool. For leased vehicles, you'll be asked if the vehicle was donated and if the vehicle is used to transport patients in the reporting year. So fewer questions during this section, but definitely questions that you're going to need to have answered. Other vehicle costs, such as non-ambulance. So in this section, you'll be asked about vehicles that were used to respond to ground ambulance calls or support ground ambulance operations that are not ambulances. We're talking about things such as SUVs, trucks, QRVs, fly cars, lead cars, sprint vehicles, supervisor vehicles, and all of those different types of vehicles that you might have. In this section, do not include vehicles that meet the required for ambulance in your jurisdiction because you've already reported them. The ones that were asked about in the previous section, make sure just not to include any of those, and also don't include any air ambulance services. Next, you'll be asked about any leased and non-ambulance vehicles, including vehicles that have been purchased, gifted, or donated, that were used to respond to ground ambulance calls or support the ground ambulance operations. So you'll be asked about mileage. So what's the total number of miles traveled by a non-ambulance land vehicles for any reason during the reporting year? Again, it's really important that you're gathering that data now about all of the mileage that's being put on your vehicles. And then you'll be asked about the water vehicle miles. If you do not have any water vehicles, your answer to this will be no. So you'll also be asked questions regarding depreciation expenses. As we outlined before, please report the depreciation expense captured for standard auditing purposes. So here's what your questions will look like in this section. If you own the vehicle, you will provide either the annual depreciation cost or the acquisition cost if purchased during the reporting year. The type of vehicle, so fire truck, land rescue vehicle, water rescue vehicle, and other vehicles that respond to emergencies but are not designed to transport vehicles or transport patients. So those QRVs, fly cars, sprint vehicles, all of those others. Only acquisitions costs are reported if you purchase the vehicle outright during the calendar or the reporting year. In general, you'll be able to use your organization's standard approach to calculating depreciation expenses. So if you calculate depreciation expense, like we said before, for multiple purposes, those tax incentive purposes, we actually want you to report the depreciation expense for standard auditing purposes. So that straight line annual depreciation has 3 different inputs for it: the purchase price, the estimated useful life of the vehicle in years, and the salvage value. So the annual straight line depreciation for a vehicle that's $100,000 for the purchase price, the salvage value of $20,000, and an 8-year estimated breakdown would be the $100,000 minus the $20,000 divided by the 8 years, or $10,000. I'm sure you'll have some questions about that, so please make sure that you ask those questions at the end. So only report the acquisition costs if you purchase the vehicle outright during the reporting year. Annual loan or interest costs of ownership that are not reported previously will get reported here. So then they'll ask what type of vehicle it is. This will be a pull-down menu. So a fire truck, land rescue vehicle, water rescue vehicle, a vehicle that responds to emergencies but is not designed to transport vehicles. Again, those fly cars, supervisor vehicles, sprint vehicles. Now we're going to move on to equipment, consumables, and supplies. So for capital equipment, we're going to go through a little bit about capital equipment. It's used entirely or in part for ground ambulance services during the reporting year. So capital medical equipment refers to the equipment that can endure repeated use, but is not limited to defibrillators, ventilators, monitors, power lifts, and all of those things. So you're going to have that annual depreciation expense for that capital equipment, and you're going to enter it. Maintenance, certification, or service costs, you're going to also enter those amounts. Next, you're going to take a look at the percentage of capital equipment attributable to ground ambulance services during your reporting year. So if you are a ground ambulance service only, you're going to put 100%. But if you're not, your percentage is going to be less. Did your organization have any costs associated with medications during the reporting year? If yes, you can pull these costs separately from your other costs of medical equipment, then you'll report those costs as a separate line. If you do not have any costs for medications, you'll be asked to select reasons the reasons why you don't. So things like the medications are supplied by a hospital or hospitals, the costs are paid for by another entity, or we just don't stock medications on our ground ambulance. So what's the total cost of other medical equipment, supplies, and consumables your organization purchased during the reporting year? So you include all of those medical supplies and consumables that were not reported in any other category. And next you'll report the percentage of medical supplies that are attributed to ambulance only. So if you are only a ground ambulance, again, it'll be 100%. If you are not just ground ambulance, it'll be less than 100%. So please report the following for capital equipment your organization has purchased and used for ground ambulance services during the reporting year. Non-capital equipment refers to things that can endure repeated use. It includes, but is not limited to, computers, dispatch equipment, furniture. You'll enter, again, a depreciation amount for those items, and then a maintenance certification or service cost for those items. Next, you'll be asked about the non-medical equipment expenses attributed to only ground ambulance services during the reporting year. So again, 100% would go in this category if you're ground ambulance only. If not, it would be less than 100%. And then they'll ask you about uniforms. So what's the percentage of uniforms that's used by your ambulance service? 100% if you're a fully ground ambulance service, less than 100% if you're not. And then everything else. So office supplies, paper, postage, all of those other things that's purchased. If any of it was shared with other businesses, you need to make sure that you're only reporting the costs that are associated with ground ambulance. And then any non-medical equipment and supplies costs, make sure that you're parsing that out and allocating that appropriately. So other costs, there'll be items that weren't covered in all of those previous sections directly related to supporting your organization's ambulance service. Include only the costs that were not covered earlier in the instrument. In general, if you report amounts specific to your ground ambulance operations, so 100% goes if you're ground ambulance only, less than 100% if you're not. If you report an amount reflecting costs for your ground ambulance and other operations, for example, fire, police, or other Medicare providers, then you report the total associated with your organization's ground ambulance operations only. So again, and we're going to just keep reiterating this, make sure that you're pulling out the air ambulance service information from your responses. So please report your costs incurred for outside contracted services, which is fees paid, including labor and supplies that were not previously put into the instrument. So dispatch, call center fees, things like that. So please select all that apply and indicate the total costs for each outside contracted service, and if applicable, the percentage that's attributed to ground ambulance. Make sure to not include any costs that are already reported in the instrument. So here you're going to indicate if your organization incurred any of the following expenses. So biohazard removal, dues and subscriptions, board of directors expenses, training materials, all of those other expenses. They should be partly or entirely related to supporting your organization's ground ambulance. Do not include any costs that were already reported in that instrument. And we'll be saying that again and again and again, because it's easy to get in the pattern of reporting and recording, and then all of a sudden you go, I think I've already reported it earlier. So 911 services, service fees, taxes, workers' compensation, insurance, if not already reported in the labor section, auditing fees, and more. I'm almost done. I have one more slide here. So other costs. So please report total expenses by source of your reporting year. And if you have multiple NPIs, please report the allocated portion of the miscellaneous costs incurred for the specific NPI based on your organization's approach and for allocating costs. Section 12 is total costs. As a way to cross-check your total costs reported throughout the instrument, please provide total expenses of your NPI for the reporting year. The total expenses reported here should include all operating and capital costs, including costs for services not related to ground ambulance services. And I'm going to pass it off starting at section 13. Thanks.
All right, everyone. Home stretch here. So we are roughly 90 minutes into the presentation, and We are roughly 90% through the data collection instrument, and we are only now turning to the other half of the equation, which is your actual revenues. So what they ask for in this section is relatively straightforward. What they want to know is all revenues that were received during the period, well, with respect to transports that occurred during the period, the data collection period. Where this might get a little tricky, though, is that they do ask for it broken down into specific categories by payer. One being traditional Medicare fee-for-service, another being Medicare Advantage plans, Medicaid, Medicaid managed care, other federal or state programs, commercial insurance, self-pay, etc. Why this can be difficult for some people is that we may have historically used different groupings in our systems under our payer types. For instance, we may combine Medicare traditional fee-for-service and Medicare Advantage into a single category. What they want us to do is to break that out. So if you are one of those entities that does consolidate all Medicare revenues into a single category, it's probably in your interest to go back now and start breaking them out and to then go backwards and undo or separate out the specific payers for the beginning of the data collection period. If you're a year 3 or year 4 reporter, I would strongly encourage you to just make sure that your payer types align with the list in the data collection instrument. It will be significantly easier if these are set up appropriately now than to try and go back and recreate it after the fact at the end of whatever the data collection period is that you're being asked to report on. Just a few other tips to keep in mind here. When they ask about revenue, you're reporting revenue using your normal accounting practices. So similar to how you define your expenses, if you accrue revenue based using an accrual method, you would accrue the revenue that way. If you do it on a cash basis, you would do it on a cash basis. If you're accrual based and you do adjustments based on the actual results and you've closed an account, you would do those adjustments as well. And then if you can't separate out patient pay from other categories, what we recommend is that you don't report it under the patient self-pay category, just list it under the patient's primary payer category. So for instance, if you don't separate out the co-payment or co-insurance portion of a commercial payment, just put it all under commercial insurance. In that instance, then what you would be reporting for patient self-pay is essentially uninsured patients. Scott, can we advance one, please? All right. After we've gone through the various insurance payer types, then it's going to ask you for other sources of revenue. And the way it will ask is, did you receive any revenue in the particular category, yes or no? If so, then enter the dollar amount, and then also the percentage of that revenue that's attributable to your ground ambulance services. So if you have multiple MPIs and they're all paid by the same facility, you would need to allocate the percentage for this particular NPI. If you are a fire department or you otherwise have other non-ambulance lines of business and that particular payer source, facility, et cetera, pays you under multiple product lines, then you would also need to distinguish what percentage is attributable to ground ambulance versus other sorts of operations. So for instance, if you lend out your employees to staff a hospital emergency department, that was somewhat common during the early stages of the pandemic, you would not be entering that under ground ambulance services, but rather under sort of a staffing arrangement sort of thing. And this is a fairly comprehensive list of other revenue sources. One of the interesting things for Scott, me, and the rest of the ACE faculty team, Michelle, is when we went out and we started, we sort of whiteboarded and asked people what the various sources of revenue streams were. And, you know, about 6 to 9 months in, we thought we had heard everything. You know, but sure enough, we were consistently surprised by the various types of revenues or the creative ways certain people had found to increase revenue streams. So among other things, they will be asking here for membership fees that you collect. So for instance, if you operate a subscription program or a membership program, an arrangement where I can prepay a fixed amount and in return, I get a waiver from all or a portion of my cost sharing amounts that I might incur if I take your ambulance. Those fees would be reported here. If you get charitable donations, they would be reported here. If you have surplus monies that you invest, those would be listed here as well. Or any other sorts of capital transactions, capital market transactions, they would be listed here. If you're subsidized, that would be included in this list. If you have enterprise or utility or you collect a millage, that would be included here as well. And then finally, it's going to ask you whether or not you incurred any revenue from the sale of an asset or service. In other words, did you sell something at a profit? In which case, then yes, you would be reporting that gain here as well. Bond financing, special purpose grants, the list goes on and on and on. And then finally, there's a catch-all at the end for other, if it's not otherwise listed in here. As a reminder, please do not report any revenue source in either multiple sections of this section 13 or if it's otherwise reported anywhere else. And I think, Scott, that takes us through the revenue section. I will turn it back to you for some last thoughts, and then we'll open the floor for questions.
Yeah, sure. Well, thank you, both Michelle and Brian. And I know we did see a question that came in here. We are a DBA of a volunteer fire department who pay the mortgage and the utilities. Are we able to report these costs? And I had asked a clarifying question. Number one, DBA essentially means that you are actually usually one legal entity that's doing business as. And so I'd be interested to know if whoever the reporting entity is will be tied to that NPI. So whoever it is that's paying those costs, if it is the NPI holder, then you would be reporting those costs. If somebody else is paying those costs and your organization is not being charged that cost, then in that instance, let's say if you're a municipal agency that the town is paying the cost, that cost does exist. If essentially another entity is donating that cost to you, then in the form of a donation, right, you wouldn't have to report that cost per se because it's not an actual cost your organization has. If there is a number and I don't know, Brian, if you feel differently about this, if in fact the DBA has or if let's say, for example, another entity is donating that money to you as a donation, then my belief would be you would report that amount as a donation in the revenue section, even though it wasn't an actual. That would be how it would be handled, correct? In your thoughts?
Yeah, I think that's right. I think the only sort of nuance I would add is if I guess we're calling it donation, is coming from an affiliated entity. I don't know that I'd necessarily call it a donation. It would likely constitute income at the NPI level that we're discussing, and therefore it would be reported as another source of revenue. It wouldn't neatly fit into any of the other, the designated categories. It would probably have to go in that other field. But just be mindful if it's funds today in return for some future obligation going back to the grantor. In other words, essentially, if it acts as debt that you're incurring, then you would need to balance that against, right? It's not really revenue per se. It's more the proceeds of a financing transaction.
Right. All right. So just quickly, the immediate actions that we've been telling folks to do now, and understandably, they'll recognize that we're 8 months into, if you're reporting on a calendar year, you're 8 months into the year. And so we're a little bit behind, but again, better to start now. And then if you have to go back and fix whatever you hadn't done already, but just immediate actions. If you're not sure if you were selected, well, you need to find out if you're selected. If you can't find the information, what I would argue or what I would suggest to you strongly is when you go to the CMS ambulance service page, There were two, the two that are published right now are the two entities that are reporting their data in this year. And Sam kindly just, I think, posted some of this stuff here in the chat. The two Excel spreadsheets that are available today, what I would suggest is don't look by state, don't sort the document by state, look for your NPI. In some instances, there were people who were selected, but that weren't listed in their state. And we're not really sure the reason for that. It may be that the information in PICOS was off. It could be that their billing agent was in another location and for whatever reason they were notified. Look by NPI. So if you don't know if you were selected, what I would say is you need to find out. If you need help with that, just contact us, hello@amils.org. If you weren't selected this year, well, then you need to know that you are selected for next year, period. So just be prepared. All right, and better to have this information all squared away and your system set up all in advance than and be able to do this prospectively rather than having to go back and try and put the toothpaste back in the tube. Either way, though, sooner rather than later. I would assemble your team. So if you're an organization that uses a billing company, recognize some billing companies are offering to do this for you, but just recognize typically a billing company only has the revenue section of the tool. So either way, they're going to be asking you and your team for a whole bunch of information. If you don't have a team, that this should be part of your discussion because it is incredibly important. Again, there is a pretty significant penalty, 10% of all of your Medicare money. And for given the percentage of people, percentage of the payer group that you have, generally Medicare is the biggest one. What I would suggest is that won't be a small amount. Make sure that you're talking with any of your vendors or your town hall, engaging those folks for whom you may have to be collecting information. Make sure you contact your MAC. If you haven't already done so, contact your MAC, stay in touch with them. If you were selected and you didn't talk to them about whether you're reporting on a calendar or a fiscal year, you need to do that. So just touch base with them. Subscribe to Amber if you haven't already done so. It is a free recognizing how critical cost collection is. It is a free software. And again, one of the things that I'd like to say is, and I'm getting a little notification that my internet's unstable. Hopefully it's not in fact impacting that. But what I would say is recognize that in the collection of data, like trash, you better know what people are going to do with it. It would be nice for us to have a robust data set through Amber that we could, if need be, challenge some of the CMS information. I don't know that that'll happen, or even better, actually validate some of the information that CMS is coming in with. Review PICOS. If you've not done so, the Provider Enrollment Chain of Ownership System, formerly your 855B form. What I would say is review that and make sure your information is up to date and accurate. You're supposed to be in there on a regular basis anyways, when you change practice locations or add vehicles. And whenever you revalidate, make sure that you are familiar with that. Don't just leave that necessarily to your billing company. Take a snapshot of your personnel at the beginning of the year. If you haven't done that, take one now, and then go back and just review anybody who had a personnel action change or something like that. Tracking your volunteer hours. If you have not done it yet, you do need to, so certainly begin now, and then figure out a way to ascertain what the number of volunteer hours that were used so far are. Go through and update either your dispatch total time on task, not just, hey, we're clear of the hospital, but still have a 60-minute ride back to the service area. What you really want to do is understand that transport, that 60-minute deadhead time back to your area is part of that total time on task, to make sure that there's a mechanism to capture that. If you haven't already done so, snapshot of your vehicle mileage. Although most people are tracking vehicle mileage on an annual basis anyways, just make sure that you understand how many miles did those vehicles in your organization travel. Check your payer categories. A lot of people, when I do rev cycle consulting, I will find some of the Medicaid or Medicare replacements listed in the commercial insurance area. That really isn't the right way to do it. When they're paying similar to Medicare or Medicaid, or they're a Medicare or Medicaid payer, you want to make sure that their category is in the right place. So making sure that you've done that, making sure that it's accurately capturing revenue. As I had mentioned earlier, certainly if you have questions, you can send your question in. Hello@amils.org sends a question into our ticketing system. the 10 or 11 of us that are on the faculty, and by the way, we are trying to find who could potentially be regional faculty, because again, we will be judged by the worst submitter of data. So it is important that we get this word out for every one of you who have engaged. For every one of you who have engaged, there's probably 10 to 15 or 20 that have not. There are 13,983 ambulance services in this country that bill Medicare. I guarantee you, we have not seen 13,983 attendees to these educational programs. So if you would, please reach out to your friends who you know may or may not have the time or the desire or the interest, and make sure that they understand how important this is. So I'm going to pass it over to Sam to read through some questions, and then possibly, I'm not sure if we're going to do a quick demo on Amber. I know we're running a little late on time, but Sam, do you want to pick up with those questions?
Sure. And we have a few pending from the chat, and once we're through with those, we can take any questions if anyone wants to raise their hand or unmute as well. The first one that came through is, we are switching our medical command who will start picking up a lot of costs. Since we are mid-collection period, how do we best report this?
So I'm not exactly sure I understand switching medical command. I'm guessing you mean medical control. So if where you're getting your medical control from, so if you previously contracted with one hospital, but you're switching to get medical control from another hospital, what I would do is whatever out-of-pocket costs you have associated with that, I presume if you paid for a year, you'll get part of that cost back. If you don't, and it was a real cost, and then you had to pay a medical control fee to a new facility, then you will report them both, because it was an actual cost during the reporting period. So I'm guessing that's what you mean by medical command. If not, please plug something else into the chat.
Thank you. If you have a vehicle at the beginning of the reporting year and dispose of the vehicle, should it be counted for the reporting year?
Yes. So a couple of things, a couple considerations there. Number one, you would of course track the mileage between the beginning of the reporting year and whenever it was that you got rid of it. So if you replaced the vehicle, let's say it was ambulance one, you had ambulance one, and ambulance one put 50,000 miles on it in the first 6 months. Halfway through the year, you replaced the old ambulance one with the new ambulance one. Then what you would do is tack the mileage there, and I would report the costs for both new and old ambulance one that you had during that reporting period. If you then, let's say you sold the old ambulance one, then you would report that piece in your revenues section, probably in your other revenues, and then you would also record in your expenses the purchase or whatever out-of-pocket costs you had, whether it be vehicle leases or vehicle purchase. And Brian's going to jump in on this in your expenses side. Brian, do you want to augment that answer?
Oh, no, I was just getting ready for the next one. I agree with how Scott described it correctly.
Yeah, and then of course, again, if you traded in equipment, again, you just need to handle that like you would any accounting process, and to the extent that you can, and I know for some of you folks, you're like, we don't have an accountant, we do our own books and QuickBooks, that's fine. What you want to do is just make sure that you're as accurately as possible reflecting that exchange from the old equipment to the new equipment, getting rid of, including whatever costs you had in the first half of the year and including whatever costs you had in the second half of the year. So hopefully that answers the question.
Thank you. One from Heather is that she has heard from some entities that they are depending on their billing company or feel that this is a responsibility of the billing company. Can you address who is ultimately responsible for?
Sure. So I think there's really sort of 2 or 3 questions embedded in that. In terms of who is ultimately responsible for the report, the answer is the provider. So if you do rely upon your billing agent to submit the report and they do not submit the report, you are liable. You will be the entity that bears those consequences, including potentially the 10% reduction in your Medicare payments for the following year. As a general proposition, an agent is not liable to the outside world for its actions. the principal. So if you have a billing agent, you are the principal. You are ultimately responsible for everything the billing agent does. That is true from liability for improper claim submissions. If you trust them to do your Medicare enrollments and they make a mistake, you will be the one that bears the consequences. I have probably dealt with 2 or 3 dozen companies in the last 5-6 years that have lost their billing privileges because their billing agent did not properly revalidate. So as with anything else your billing agent does for you, you are ultimately responsible, which means that you have to be involved. But in the case of the cost data, I really am not sure that your billing agent is in a position, frankly, to do it for you. As I indicated, there are 15 sections in the tool, and only one of them deals with revenue, which is where your billing agent would actually be in a position to have the information, right? All of the information about your costs are something that probably does not sit within your billing agent. So at best, you would simply be providing them the information and they would be putting it into the data instrument, which means that frankly, you're going to be involved in it anyway. So I understand the desire to off-put this to billing agents. I also understand the desire of some billing agents to assist their clients with it, but I think it's probably, all things considered, a bad idea. As for the notion that it might be the responsibility of the billing company, that boils down to your agreement with your billing agent. I think it is highly unlikely. I've been on the side of representing billing agents where the client has indicated that this is a responsibility. I assure you it's not addressed in your agreement with your billing agency, right? So I do not think it is a best practice to rely upon your billing agent to handle this. I don't think they're properly equipped to do it. For starters, they don't have your cost information, right? They don't have your payroll information. An accounting firm might be a better substitute. They would have access to most of the information here, including the revenue side. So, but again, ultimately you're responsible. So before they hit submit, I would definitely want to take a look at it.
Great.
Michelle's got anything to add?
No, and I think it's really important to start connecting with your own agency and other departments in your own agency right now, if you haven't done so already, so they know the time frame it's going to take them to pull all that data. Because you're not going to be able to pull it likely on your own. You're going to need those partnerships in your own agency and outside your agency if you use a billing company.
Great.
Thank you all. I did drop a couple of resources in the chat on this topic as well. One is an infographic showing you where your cost collection data lives by category that all faculty had worked to put together. So it follows the 13 sections of the tool and gives you an idea on where you need to go, what systems, what departments, what partners you may need to contact to get that data pulled together, as well as a quick take from Michelle that talks about how cost collection is bigger than billing. The next one I think is a clarifying question or relates back to the first. If medical command or control is provided by a medical facility with no associated fees, I assume there is no need to report this because of no cost.
Yeah, I would agree with that. Yep.
Yep.
That is all the questions that I see in the chat. If anyone else has a question they may have received via private chat or would like to unmute themselves to ask a question, we can do that now. And if there are no further questions and the group is interested, we could do a quick demo of the Amber software as well.
Sam, I presume you want me to stop sharing my screen so that you can share?
Yes, yes. If the group is interested in the Amber demo, then I can certainly share that from my screen. Thank you, Jack.
Samantha, I'm going to say go ahead and run through the demo, and then if people want to stay on, they can see it, and then if they have to go, they can go ahead and disconnect. But I did want to let everybody know that following the recording, I will send out a link to the slides, a link to the EMS agencies that have been chosen in year 1 or year 2, the CMS Ambulance Service Center data collection links, I'll send that as well. And the data documents, where your data lives, the AAA registration for the conference, and then the other links that you send, and also the hello@ambulance.org if anybody has any questions.
Perfect, thank you. So emsamber.com is the URL. It's super easy, super simple to find. And if you are not already set up with a username and password for Amber, you can click this button here, request free access to Amber. It will take you to our quick and simple web form that asks just a few basic questions and sends this over to us. We review and respond to all of these requests within 30 days, usually quite a bit quicker than that. If you do already have a login, you can go ahead and click on this button here, login. It will take you to your login page, of course, give you the quick disclaimer that we're not providing legal or financial advice. And we'll lead you to this question here. You can see we have a number of surveys in here that we've built out to help services along the way with provider relief funding and our work on balanced billing as well. For this process, cost data collection is the one that you'll want to focus on, and you'll go ahead and hit launch survey. As we talked about before, everything here is driven by NPI. So the first step that you'll do is go ahead and add an NPI. You can choose a nickname for it and add your NPI there. A couple of quick links as well. We also have browse resources, which is a quick link to the encyclopedia. You can see at a quick glance that our encyclopedia follows the exact same layout as the actual tool. So anywhere you click in here, you will see a tool for encyclopedia match of definitions and terms, which makes it pretty easy to navigate. We also have a quick link to an Ask the Expert. So as you're doing this, if you have questions that come up, please don't hesitate to click contact us, reach out to hello@ambulance.org, or email any of us your question, and we will definitely be there to help you along the way. Once you have your sorry. I clicked back too many times. Once you have your NPI, you can go ahead and start entering your organizational demographics here. And again, some of this information does drive the skip logic built in throughout the tool. If you have multiple NPIs on the NPI screen, you'll be able to see a quick snapshot of all NPIs entered and the various status of completion throughout. I am not doing a very good job at completing my reports here on this screen. Again, it follows the exact layout of the CMS printable cost collection instruments and goes section by section by section. In the service area, I'll just kind of show you the zip code tool that Scott had talked about. Let's see. Sorry. Sorry, I don't see where the here's where you can draw the shape. So this is where you can click and draw your shape on the map, and it will pull in all of the zip codes selected in that area. And then you will be able to cross-check and make sure that it's all of the zip codes that you had wanted to add. Billable transports, revenue, labor costs. We'll preview the labor screens here. And you can see all of the categories that are outlined. You have column headers for number of paid staff, number of volunteer staff. If you don't have that category and related to ground ambulance or not related to ground ambulance. And I know we're closing in on time here, so I will be quick. You will see a summary at the end. When you click finish, again, you can choose which MPI you want to finish, and then that will end up with an exportable document for you to review as well. One other thing that's important to note too is we do have a lot of data validation built into the tool. So if you are entering data and you go to the summary screen, you will get notifications if something doesn't seem right. So if you've entered numbers that don't match, or you've selected that you don't have volunteers, but then you're trying to enter information about volunteer hours or anything like that, you will get a notification that something doesn't seem right, and it will take you back to the exact location in the tool where there seems to be a question, and allow you to fix it and validate it before you finalize your data. Again, we're giving the Amber Access away for free to anyone and everyone who wants to use it. I have dropped the information in the chat about that as well, and I will also share it with Heather for anyone who's not already looped into Amber that is interested in being looped in. With that, I know that took us to the top of the hour. Scott, Michelle, Brian, Heather, anything else to add?
I want to thank everybody for taking the time, and hopefully if you have any questions that you know where you can reach out, we're more than happy to help.
Thank you all very much. This was incredibly useful information, and I know that AAP members are going to be really grateful for this. So I will share, and I have been sharing as much as possible, but you know, it's one of those things, people don't read emails, and then all of a sudden it's like, oh my gosh, I gotta, you know, do all this now. And Michelle and I talked about how reactionary we can be at times. This is very helpful. I thank you very much.
Thank you.
Thank you all.
And with that, we will go ahead and close out. Again, if you have any feedback, please let me know. If you want to see more of these lunch and learn options, please send me that as well. And everybody should have my email address, but it's executive director@aa-pa.org. And thank you all very much.